Good morning to everyone, and welcome to Nightmares in Ureteroscopy, in which we are going to dive into the less glamorous side of this common technique, but sometimes it's not that common. And I have the privilege to chair this session and to moderate this outstanding panel of experts, Dr. Cesare Scoffone and Giorgio Bozzini from Italy, and Dr. Oriol Angerri and Gemma Duque, who is coming from Spain. In the next minutes, I'd like to challenge them with some real case situations and challenging scenarios. And, well, the idea is to turn these nightmares into learning experiences. So I hope you will enjoy. So let's kick off explaining that they are here because they are experts. And at the same time, they are experts because they have come across all the possible complications, and more importantly, they have learned from them. If you don't learn and you analyze your own series and discuss with your team the possible complications and the variables that led you to complications, you never learn. And if you never learn, you will never be such an expert as these colleagues here. So, first situation, Cesare, I start with you. We start with the flexi, but we see that very tiny ureteral orifice. Should we proceed dilating? Balloons are here to stay, or balloons are for birthdays? What's your take on this?
My concept is a concept that Professor Scarpa gave me 25 years ago, is the respect of the ureter. So no dilatation of the orifice, no dilatation of the ureter. What you can do, even if you are seeing a very tight, very thin orifice, you can put a guide wire, and with the second guide wire you can see also the elasticity of the meatus, because sometimes it's small, but when you open with two guide wires, is a meatus that is fitting the ureteroscope. So I try to do this. If it's not possible, I put a guide wire with a budget, and I will do the procedure 1 week after.
You try to explore with a semi-rigid in order to create endoscopic dilation, more control?
Yes. This is the first step. One guide wire inside and second guide wire into the ureteroscope in order to have this railway entrance to the orifice. And normally, in 80% of the case, with the small ureteroscope, you can approach every ureter. I mean 6.5 Charrier ureteroscope that I'm using in our daily practice.
Okay, Oriol, how long do you wait if you place a double J for this passive dilation to happen before rescheduling the patient?
So one thing is theoretically, and the other thing is in the practical clinic. So practically just 2 weeks, but in the literature we can see that in 10 days it's enough, and there are some authors that say that in 1 week it's enough. Okay. But I would wait 2 weeks at least.
Giorgio, anything to add? No? Or yes? Something different?
I think that, the exit strategy, the safe exit strategy is the JJ stand in. So if you are not confident, you are still in your learning curve, put a JJ stand, wait for 2 weeks or 10 days, and you will find out a motorway at the end. And if you feel comfortable, you can dilatate with the semi-rigid ureteroscopy. You can dilatate with the inner sheet of your sheet. So you can just take out the inner sheet of the sheet and just try to reach the ureteral junction. Just do it gently. So respect the ureter and try to dilatate the best and gentle way you can. But the exit strategy is the JJ stand.
Okay, so
Dan,
yes?
I would like to add something because it's not just a matter of the ureteral orifice. So if I'm seeing the ureteral orifice is narrow, I would like to see how is the rest of the collecting system. It means that I'm always doing a retrography to see perfectly the anatomy.
So to me, the three messages here in this topic are: be gentle, respect the anatomy, and balloons are for birthdays, probably, yeah? So let's move to the second one. I used the force, I wasn't gentle, and can we run the video? The video should be running. I don't know if you can click for me in in the computer. If not, okay, here it is. So here we have a nice hole. At least I have a guide wire. Dr. Duque, what did you do here? It's at the beginning of the procedure. We haven't started the laser tripsy, and we created a hole with, I think it was with the semi-rigid. Semi-rigid went up blindly. Next message, never advance if you don't see. But what did you do? Would you stop? Would you keep on performing the surgery? Grab a mic, please.
I think this is a small perforation, but I think if you you have performed your guide wire, I think I put in a double G stent and wait later. I think so.
Yeah. Oriol?
So can I see the image again? Because I think that the hole, you have to see the hole perfectly to decide if you are going on or not, because
It's a little bit of fat there. It's a hole. It's not in the entire circumference of the ureter, but it's a hole there.
yeah. And the stone, how big
The
is
stone
it?
is in the kidney. This is probably the lower part of the ureter, and we have still the stone up there. So I think an access sheet is necessary to complete.
If you need an access sheet, for sure, I'm not gonna proceed with the surgery. I
Yeah.
will place the double J.
I think that the four of us can agree on this. Yeah. So let's move to the next one, which is at the end of the procedure. I have this. I remove the access sheet, and I see that my access sheet was not that didn't went up as smoothly as I thought. So sorry. What did you do, Giorgio? Stand, and for how long?
Yeah, I will keep a stent 1 month, 3 weeks. So give the time to the ureter to heal. The factor will be when you will remove the stent to see if a scar and a stenosis will act in that ureter. And so just make a study or just a US after 2 weeks post the removal of the JJ, just to see there's no hydronephrosis or check. You have to check if that hole that will heal, this hole will not be a problem at the end of the procedure, could be a problem when it's healing if will give you a stenosis.
So I mean, Giorgio, that you are saying somehow that silent obstruction after ureteroscopy is underreported, probably, because no one checks systematically with ultrasound that the kidney is dilated after a flexi.
Yeah.
Am I right?
Well, when you go out with your sheet and with your semi-rigid or rigid ureteroscopy, take always a look when you go out, so you see properly if you have damaged or there are some injuries to the ureter. If not, it's very unlikely that you have a problem after that. So I'm not telling that anytime you remove a JJ stent, you have to do an ultrasound. But if you see an hole or an injury like this, you should keep in mind that this kind of situation can lead to a stenotic ureter.
So in these cases, you should check.
Yeah.
Do we have data, Cesare, about what's better, to live for 2 weeks, for 1 month? Is it evidence behind?
Can I tell my impression? I am not so afraid about the hole.
Yeah.
I am afraid about this white imaging of the ureter. It means that you insert your ureter as a sheet, but the ureter was there is a spasm on the ureter. So this could be a problem for the patient for the next stricture, not the hole. This hole, I think that it doesn't matter if you don't have extravasation. Is not really important. In this case, in my opinion, I will leave for sure 2 weeks the double J, but after 1 or 2 months, in this kind of patient, I am doing always a renal scan, not an ultrasound. Also an ultrasound, but the ultrasound, in case of dilatation, you don't know if is a dilatation due to the stone that you have before. And with the renal scan, you can see if the ureter is draining or not. Because it is important to do a really early diagnosis of the stricture. This is very important.
Okay, I need to advance, but I think that we can wrap up this situation saying that never advance the ureteroscope blindly, don't force, and when you find this kind of ureters that are quite whitish and not reddish, don't be calm, be gentle with the advancement of the axial sheath, otherwise you can create a hole. Just a quick comment, Gemma?
Yes, only one comment. And in this case, I think I suggest to perform one ureteroscopy after to remove the double G. I think so, to give another endoscopic vision and to know what the future of this stenosis, possible stenosis.
Okay, so let's see this. Can you click on the video, please, because it's not running? So this is me performing a flexible ureteroscopy under spinal anesthesia. Probably sometimes you try to laser and then the stone moves around and you never hit where you like to hit the stone. So, Oriol, should I ask systematically for general anesthesia in order to control the kidney motion? What's your take on this?
So yes, we are doing all flexible procedures under general anesthesia, and we try to collaborate with our anesthesiologists. We ask them to do some long apneas, depending on the lithotripsy and what part of the lithotripsy we are. So long apneas, and then we keep going with the standard respiration, and then all the otherwise we try to do this kind of smooth superficial respiratory movements to avoid this high movement of the kidney.
Okay, any another tip
No,
or trick?
we did 1,000 ureteroscopy in spinal anesthesia in our hospital because we did the spinal anesthesia outside of the OR. So for the changing,
Yeah.
we did a lot. But today we are doing all the flexible ureteroscopy in general.
Okay,
anesthesia.
because sometimes you hit when you don't like to hit. You see the stone quite clearly, and in a few seconds, you don't see. It's the Red Wedding from Game of Thrones. So what did you do, Giorgio, when it happens, when you don't see anything? Do you increase the pressure? Do you stop and leave for another day? Do you call another colleague?
I cannot call another colleague,
Okay,
usually.
you're unlucky.
I'm lucky. The fact is that, well, if it's red, something is bleeding, and you have a scope in your hand. So one trick I can is just to do a pielogram, just because when you are using the contrast, you can see better, and you have a better situation. So you can this time see where the stone is and see if something is bleeding. And if you have an holmium of the new holmium, I mean the Magneto by Quanta, the Moses by Lumenis, or you have a TFL. Remember that you can use this laser, and you will see tomorrow, also for enucleation. And in enucleation you have also the coagulating option for this laser. So if you can see where it's bleeding, you can see also when you can act to stop the bleeding. Well, actually you can stop if it's just a vessel. If it's something bigger, you have to stop. But the problem is that putting a JJ stent in this kind of situation will not stop the bleeding if it's an arterious one and not a venous one. If it's a venous one, not a problem. You can put a JJ stent and redo the procedure. But usually, you can just see the vessel, see where it's bleeding. You can just coagulate that bleeding, and you keep on with your procedure. So it's something in all the complications seen till now. I mean, despite the one that you see on live, the bleeding is the one that really do not make any big concern on me.
Okay, any short comment, Cesare?
Yeah, I think that you can also wait for 1-2 minutes, and trying to clean a little bit with some irrigation. Normally, if it's not a big artery, is stopping and you can follow your surgery. Inflexible.
I'm going to follow your advice, and I irrigate it. I probably have irrigated too much. On the left-hand side, you see a good pyelogram. On the right-hand side, you see a lot of extravasation. This can happen. So this is the point of high intrarenal pressure. Remember, when you use syringes, don't force, because you never know the compliance of the system. There are systems that dilate quite well, and there are systems in which, with a few millimeters of irrigation, you start to have fluid all around, and it can lead to septic complications. Well, this is something, this is a déjà vu. This is, can you play, okay, this is a stone in the lower calyx, Gemma, and I was quite greedy, yeah, is it the word greedy? And I tried to grab it with the basket to relocate it, because I learned from the experts that relocating a stone from the lower pole to the upper group is better. Bad choice, because on the right-hand side you see that my basket got stuck. Well, what I did is I could manage to release the stone, but the message, Gemma, is not to force here.
Yes. All forces maneuvers in flexible ureteroscopy, like this, for example, to remove this stone, are very dangerous in terms of security and bleeding, in terms of bleeding or another cases. If you have this situation, you can cut the handle in the exterior of the basket and go up again with your ureteroscope and make a lithotripsy to the stone and the basket to remove it completely.
But the best scenario is not to have this complication. So don't try to pull out stones through an infundibulum which is narrow, because the stone won't fit there. This is
because you don't remember that you are going in through the infundibulum.
That's
so
it.
if you see this infundibulum, it's impossible to remove stone.
That's
so
it.
perhaps you have to try to cut the infundibulum with the laser before, gently, and open a little bit more, but not trying to catch this and trying to force.
So don't be greedy, otherwise you will be in this trouble. This is something I will skip because we only have 1 minute before closing the session. And this is a nice complication. I was performing a flexible ureteroscopy for UTUC. And see what happened. I was performing, the surgery was performing quite smoothly. And I start to lose vision. And game over. I don't see anything more. And at the same time, I tried to pull out the ureteroscope to see what happened. And it didn't come out. It got stuck inside because it broke. It broke. This is a complete breakage of the deflection system of the ureteroscope, and it got stuck. How did I manage to pull it out? I put a guide wire through the working channel using the stiff part in the tip in order to strengthen the tip of the ureteroscope, and this way I could manage. Otherwise, I had a hook. Did it happen to any of you, Oriol, or this kind of complications?
No, hopefully not. No, and I mean, but yes, the rest is the correct way to do it, is to place the guide wire and trying to correct the breakage of the scope, but it has never happened to me. No.
Don't try to pull it out with this hook. So please don't pull out things that don't come out smoothly.
This is a reusable.
This was a reusable one. Yeah, it was a very expensive complication.
With the single use will be more frequent this complication because we can exaggerate our deflection, and perhaps sometimes will be more frequent to have this situation. Is a really good suggestion.
Okay, so I think that we have almost finished. This is the encrusted stand. This is the same maneuver that Olivier was showing today, cutting the double J in order to make room and then to remove the stand in pieces. But remember, if you the beauty of endurology, if you can postpone and reschedule patients, you can leave a double J in parallel or a pilostomy, and that's all. And we can come back in 2 days. So I think it's time to wrap up. Thanks to all the panel here. Remember this quote by Christian Barnard. I hope that today's discussion has been useful and has given to you all practical insights to improve your skills in flexible ureteroscopy. Remember that below the drapes, there's always a patient, and the patient has a family. Please, don't force and be gentle. Thank you very much.